All right. Happy winter to you in California. Are you freezing?
I know. Good morning. I feel so bad. I was telling Sheena that I was cold this morning, and yesterday it was 68 degrees. I was actually at Pebble Beach on Saturday because
Nice.
my friend's husband was playing in a pro-am. So he played Spyglass in Pebble Beach, and their 14-year-old daughter, who was on the golf team, got to play Pebble Beach. They pulled her out of school. She shot an 80.
Whoa.
So, yes.
Holy
Um,
cow.
so I love it when I see teenagers. I'm sure you feel the same way because Sheena and I were both athletes growing up. And we like to consider ourselves still athletes. But to see this girl so excited, 14 years old, playing Pebble Beach with her dad, her golf coach from high school came out to play, and then they had someone else in their foursome. And I saw a
Wow.
couple of swings of hers. Unbelievable.
That's so cool. That's a great score, too, for those that don't know, for a 14-year-old to shoot 80. That's a great score for any person to shoot. That's not a professional golfer,
I know. I can't even
especially at
imagine where she's gonna
Pebble
go
Beach.
from here, so
Oh, cool. Good for her. But
very
yes, it's
inspiring.
cold. It's cold
It's
all
cold.
over. I know our clients in Florida, too, are like in their coats and stuff. And like it looks like they're, hunkering down for Snowmageddon. Like,
Okay. Yeah.
but it's all
So
good.
so it might be cold there and it might be snowy, but we have our own issues with Mother Nature here in California. I
Yes.
just experienced 2 earthquakes this morning. So the first one was at 6:30, and it
Great
was
start.
just I just felt a little something, and I looked out the window and I was like, "That was an earthquake." And then the second one, a half an hour later, I was like, "Okay, this is really an
Wow.
earthquake." It was
And what
4
I asked you was like, did you duck and cover? And you were like,
I
what's
did
duck and
not duck
cover?
and cover, and I was telling Sheena I better look up, like, earthquake preparedness tips so
Yes.
that if another one comes soon, we got it. Yeah, we
Yeah.
gotta have a plan, just like
You
we have
have
to
to
have
have a
a
plan.
plan for our health, for what we eat, and I'm not
Yes.
prepared. So when we finish this, I'm going to go online and look up some tips so that I have a
Awesome. You
so
should text Servia. She is a master of preparing for the elements, if you will. If we get if we're in a tornado watch in Chicago or anything like that, I mean, she's the one that's waking me up. She's got a headlamp on. She's got gallons of water. We got to go down to the basement. We got to wake up the kids. And it's like, it's not that bad, but you know, she's who you want to be with. You want a bunker, you want a bunker with beef. So,
okay, alright. Well,
um,
maybe I'll send my plan to her and she can review it and see
yes.
if she
Yeah.
has any recommendations.
Yeah. I know it. I know that'll be great.
Yeah.
Awesome. Today's also Gray Shirt Club Day. I don't know if I hope everybody else is wearing their gray shirts because we are
Yes.
matching today.
Sheena and
Unscripted,
I
but
did not contact each
nope,
other. This is
nope.
just how we
This is
showed
the
up.
Monday attire. So we last week we talked about strength training. I did
Mhm.
a whole lot of talking. This
Yes, you
week we
did.
wanted to kind of maybe talk like a little bit more about the things outside of training, maybe more along the lines of hormones, like some things that we can maybe be looking out for if we're, let's say, in our late 30s, early 40s, maybe late 40s. This whole lovely time of perimenopause, and maybe some things that, like, let's say I'm 40, maybe I'm 42, whatever. And I start to just not kind of maybe feel like myself. Like, what are some of the things that people, let's say, come to you with in terms of symptoms that right away your alarm bells are starting to go off and like, oh, this person might be entering perimenopause or even menopause.
Yeah, a great question. And I'll tell you, my approach has changed a lot since we first started Beyond the Box. And what I do if somebody is in, we do a full 1 hour intake up to an hour when I meet with a new client, and I send them an intake form. If they're 38 or above, I send a signs and symptoms hormone tracker. And
Okay.
what it does is it lists a bunch of different symptoms that are broken out in 3 categories. So it's physical symptoms, emotional, and gynecological. And I think that's an important framework just to keep in mind so that we can understand and help you get a little more targeted in what's going on with you. So it looks at not only your reproductive hormones, so estradiol, progesterone, and testosterone, but this one sheet also has cortisol, insulin, and thyroid. Those are also hormones. And what it does is when people, it's just a checklist, and then we tally up the numbers of check marks that they have and gives me a clear indication of is there likely to be excess estrogen or low estrogen?
Hmm.
And the same goes for all of the different symptoms. Now, I just had a client who is 54. She just started about 3 weeks ago, hasn't had blood work in a year. So that's the second thing I do is I ask them how recently they got their labs completed. First, the signs and symptoms tracker, then the lab work.
Okay.
And I'll just give you an example. So this client checked off hot flashes, poor memory, poor concentration, dry skin or dry eyes, insomnia, headaches, acne, fatigue, and wrinkles. Okay, now
Ooh,
some of those could be just from aging, right? Like the wrinkles and then under gynecological, lighter or no cycles, vaginal dryness, urinary tract infections, and incontinence. And then the third one under emotional was anxiety, carbohydrate cravings, low libido and sexual sensation, and poor stress tolerance. And when I look at the whole sheet that she filled out, estrogen deficiency had the highest number, and that's what I just read through. So to me, that's pretty significant. And what I wanted her to do was to go back to her provider, ask for a new, full panel that they typically do, which is a CBC and a CMP. And then I gave her some additional labs to request from her doctor, including estradiol, which is estrogen, progesterone, free and total testosterone. I wanted her to get a full thyroid panel.
yeah.
Cortisol, serum lab cortisol isn't as accurate as a saliva test, but I still have her do that.
Okay.
And then we'll have her get a fasting insulin and make sure she's getting a hemoglobin A1C and a fasting glucose, which is looking at how she's regulating her blood sugar.
Right.
All of those can potentially change during perimenopause and menopause. So in this case, her provider agreed to get all of those labs ordered, which is, yeah,
Nice.
exactly, is
That's
a
a win
win.
in itself. That does not happen
That is
that
a
often.
win in itself. And so now her provider also, and I love this, her provider said, I want to know more about what you're doing with your health coach, and I want to take a look at what she's recommending, not just for supplements, food, anything else. Now, to me, like somebody else might get upset about that. I'm excited
No, it's
because
great. Yeah.
anytime a provider wants to give a second set of eyes, wants to provide their expertise, they're a physician, right? That's their lane. I am not trying to get in their lane. I'm trying to complement. I'm trying to make sure that by being in a different lane, that patient or my client is going to go faster
Yeah.
down that road, meaning they're going to get answers sooner, they're going to feel better, and they're going to get the support pharmacologically if that's what they choose to do with hormone replacement therapy with their provider. And then what I'll help them with is supplements if needed. And we'll be really strategic about that depending on what's going on with the labs and what she stated on this signs and symptoms tracker list
Mhm.
and just how she's feeling overall, what she's been eating. And then I'll also give recommendations on food and how that can have an impact. We'll also talk about some lifestyle factors like what are you doing for stress management techniques? Because if our cortisol is going up, which can happen, nothing else changes, then that client might need some more stress management techniques. Maybe they're in a
Yeah.
really big job. Maybe they have a couple of kids, some teenagers. A lot of women going through perimenopause and menopause are in the sandwich generation. They might be caring for an aging parent. They've got their own relationship with their partner. Then they've got kids. And then in some cases, their job.
Yeah.
And then they're trying to navigate their own health. And a lot of times what I see is women tend to they push harder, right? Because we know how to get shit done. And they think, oh, I must be doing something wrong, or maybe I'm not doing enough. Maybe I should cut my calories a little more. Or they might say, what's wrong with me?
Mhm.
Blaming themselves. And it's
Yeah.
nothing that they did. It's just that our bodies are physiologically changing and our needs change as we go through perimenopause and menopause. So it's about supporting your body physically, emotionally, gynecologically, right? To get the best possible results so that your quality of life is as good as it can be while you're going through these changes. As
Yeah.
one of my mentors calls it, this hormonal chaos or hormonal storm, right? Because it comes at us really fast. And It's just not knowing what to do about it. And I think also women tend to say, I can deal with this. I deal with everything. This is
Yeah.
nothing. Like, let me just like stick it out and see what happens. And, I think early intervention is definitely what I would recommend. If you don't need hormone replacement therapy or it's something else, then you have a dialogue with your provider about how to prepare for perimenopause or menopause. And then you also identify with your provider what could be going on. There could be something else. And so regardless, you're getting some solutions. And I think that is those are some key points that I don't know if that answers
Absolutely.
the question.
No, it's huge. I mean, I heard you say like it's a collaboration, right? Like where it's so nice when you can find a provider that's on you're all on the same team, right? With your client. Like your client's goals, like their health and well-being is what everybody should be invested in. And having more support, like via people, via a team, or via supplements, hormone replacement therapy, like all it is just support, right? It's not we're not in this game of like pass fail of life. Like if you somehow grit through your early 40s unmedicated or whatever. Like, there's not a gold medal waiting for you when you're 45 and you feel like crap, right? I think there is so much pressure on you. You kind of nailed it, right? Like there is this women particularly having to like take care of kids, take care of their relationships, take care of their parents, take care of others. Like there's so many responsibilities, and it's mostly we do that is because like that's the way our parents did it, right? Or like that, like our role models, our parents' generation went through it, and they didn't have any support through menopause through no fault of their own. And so like they did it, so why can't we do it, right? Like, just because they did something hard doesn't mean that we also have to go through that same hard. There's ways now that we can actually be at our best and go through these years at our best rather than people getting the worst of you, right? And like that's I never want like people in my life to have to deal with the worst of me just because I'm being stubborn and I'm not trying to accept help where there is help right now. Like there's a lot of help available. So yeah, I think that's huge, G. That's like the collaboration piece is like it's getting better too, right? Like I think there's more
Absolutely.
and more doctors out there, and unfortunately a lot of them are going to like private practice because they can't serve the people that they want to serve within like our current medical system because there's just they have so much to deal with. So when someone actually wants to know, hey, what are you doing when you leave this office, like they've got hundreds of people to see, but if they want to
Mhm.
know what you're doing when they leave your office, like that's massive. You got to hang on to that provider. That's huge.
Yeah, it is. And I'm glad you brought that up because it's no fault of the provider. I don't want
No.
to throw providers under the bus. This is the current healthcare system and a lot of times they're told what they can and can't order as far as labs. So they're going to in some cases order the bare minimum, and it really depends on your insurance, your relationship with the provider, which health system they work for. Like this patient was actually University of California, San Francisco. Lots of variables to consider. What I will say that is very promising, and I've done myself and recommended to clients, is there are direct to consumer lab companies.
Hmm.
So it does mean that you'll have to pay out of pocket, unfortunately. In most cases, however, you can submit the bill to your FSA or HSA account, and it would be covered under that account. So, like as an example, I have one client right now who has gone to not only her primary care, but also her OBGYN. So she tried two providers in the same network, and neither of them wanted to add, like, I'll give an example, was her thyroid. She had a TSH, which is kind of the bare minimum of testing your thyroid, and that number was extremely elevated. And I just asked the client, I said, based on your most recent numbers, did your provider talk about changing the dose or
Yep.
adjusting it? And they hadn't. I said, well, I believe that this warrants additional lab.
Follow
So
up.
we
Yeah.
had her get like a free T3, a T4, like how's she converting thyroid hormone, and then TPO antibodies. And that's just giving a more complete picture. Now, once again, I won't use that to diagnose or
Right.
do any things. She can then go back to her provider and decide how she wants to have that conversation if she wants to.
Yeah.
And my goal is to just educate her and then support her, supplement wise. Like, is there a supplement? What can she do for stress management? And maybe advocating for herself with her provider. And I'm a big believer in that after working in a pharmaceutical, the pharmaceutical industry for multiple years
Hmm.
and calling on healthcare providers and just knowing and helping my aging parents actually when I was going through menopause, knowing that you have to know how to advocate for yourself and your loved ones in a
Hmm.
medical setting. And I think a lot of people get white coat syndrome and they think, oh, the doctor knows everything, they know best. I can't ask them a follow-up question or I shouldn't.
Yeah.
They know what's best for my care. And I think that's something that I really want to emphasize today is that if you are not getting the response that you want or you don't have a level of trust, please go, like as an example for perimenopause and menopause, there is a wonderful website called menopause.org, and you can search a provider based on your zip code and your insurance coverage and find someone who has been trained specifically in menopause. They have to get a certification. They have to go through training modules because another provider, like an OBGYN, might be really good at somebody with fertility or
Hmm.
general gynecological care. These are all needed, absolutely.
Hmm.
Or someone just wants to deliver babies, or someone is focusing more on endometriosis. You want to find somebody who has this menopause certification, who wants to be working with women who are going through perimenopause and menopause, and they have experience and expertise.
Yeah.
And that's somebody who has chosen to specialize in working with people like you. And somebody who went to medical school 20, 30 years ago, as an example, might have a completely different approach than someone else who's seen and understands the most recent data that's been published on the safety and efficacy of hormone replacement therapy, because that has changed over time too.
Yeah. Yeah. No, it's a really good point. I have a question for you, and this has come up recently, like this week. So I've talked to at least three people that I've heard this happening to. GLP-1s, right? So I know we talked about this is on the lines of hormones, but I think you'll have a good take here. So for people that are on GLP-1s and mostly ones that are covered by insurance, they have one of my clients in particular has insurance is forcing them to increase their dose. So she wanted to start microdosing. She felt great on microdosing, had like very good effects. And insurance said, okay, now it's time to go up. And so she went up. 3 days, nausea, like just can't have 3 days after the injection. Like it's working, like she's losing weight, but like her level of tolerance for it. And I think the side effects are increasing because insurance, not her provider, she's going through MIDI, is telling her that she has to increase her dose. MIDI is trying to combat that and say, like, write a letter on like kind of advocating on her behalf, saying, like, you know what, like path of least resistance here, like she's doing great on the microdosing, let's stay here. But why can insurance do that? And why and how? Like what's going on here?
Yeah, it's so bizarre. So when an insurance company has a list of all of the medications that they cover and they meet maybe monthly, and it's called P&T committee or pharmacy and therapeutics. And what they do is they assess, kind of, and a lot of it has to do with money. I'm sorry to say that, but it's just the reality. And so what they do is the drugs that are more expensive or the medications that are more expensive, they're going to have, it's not just going to be a free for all where any provider can just prescribe a medication. So GLP-1s definitely fall into that category. So what they're trying to do is manage like who's getting them, for how long they're getting them, and how much the spend is on their behalf. So in most cases, they're going to deny that initial prescription and say, you don't meet the criteria. Your BMI isn't high enough. You're not pre-diabetic. They're going to have different criteria for different insurance
Yep.
companies. They want to keep as many people off of the medication financially. That's in their best interest. Then once somebody does start, they might even have to get an approval after they've taken it for a period of time. Let's say they get a 3-month prescription, and then the insurance company might come back and say, you need to resubmit a prior authorization so that we can approve that this patient can continue taking it. And they make you jump through hoops, and nothing has changed. And so it's just this arbitrary thing that happens that they're just trying to make it a little more difficult. Now, what you're talking about surprises me because I would assume that a higher dose is going to be more expensive for them, right? It's more drug, more active ingredient, and that does not fit the logic of how they work. And
Yeah.
so I don't know if they're trying to get people to experience more side effects so they withdraw, or it's just some arbitrary protocol that they set up when they met. The insurance company had their pharmacy and therapeutics meeting. That's something I'll have to do more research on. And I'd
Okay.
love to get back to you on that. But it really doesn't make sense. And her
Right.
provider may need to write a letter of appeal.
Yeah.
And, you know, quick way to get approval, well, it's not always quick, let me say that. You might have to jump through some hoops, is saying the medical provider will likely have to write a letter. The patient might have to write it for them. The doctor can make any edits and then they sign it. And it's, stating like increased nausea, quality of life impact, adverse impacts. The patient can't sleep, they can't work, they can't take care of their kids because of the level of nausea. We're asking for an appeal, and this is our appeal to have you bring it back down to the lower dose.
Yeah.
Yeah,
It's
and
just crazy, right? Like, why would a like what does the insurance company have to gain by making one, like, how are they able to like legally do that as well? Which is like, that just seems like, shouldn't that be the provider's job, not insurance,
yeah,
right? Again, my level of like understanding of all this is down here. So that's why I asked you. But it just, yeah, and it seems like it would be more, I guess it would be more expensive on their part to have somebody taking a higher dose, right? So it just seems that why wouldn't they want to keep it at the lowest dose possible if someone's experiencing good effects there, right? Or like positive effects, like keep it down. So it wasn't just Medi. Somebody else mentioned like using the company hers, like they were also like, I don't want to say the word forced, but like definitely encouraged, or like it was like, no, you have to go up now, which is just, it's just so, that
yeah,
would
that
be like, I
is
equate that to training where it's like if somebody's back squatting 200 pounds and they can back squat 200 pounds, and I'm like, okay, now you have to go up to 300. Like, go ahead. Like, it just seems like, it seems irresponsible, and it seems like, well, this is working. Let's just keep doing this.
yeah.
I don't know.
It's you know, you're speaking very logically and thinking critically, which is right, that it doesn't make sense. That's the point. So I do wanna do some research and find
Okay.
out. Now,
All
what
right.
I will tell you is what some providers do. This does happen, not just with GLP-1s, where providers' hands are tied. They're not able to just prescribe medication as they would like in all cases. They have to find, I don't want to call it a loophole, but they just have to find unique ways to write the prescription and to instruct the patient how to use the medication, right? Like when I went to a dermatologist, this is an easy example that was pretty cut and dry. When I had acne, like in my late 20s, it was just getting really bad. They prescribed an antibiotic called Minicin, is the brand name. The dermatologist I was seeing at the time said, your insurance company is going to want to give you the generic version because it's less expensive for them to dispense and to provide to you so they can make more money. And that happens every day, all day long. And the dermatologist said, dispense as written. That's the acronym they use, DAW. And that
Hmm.
means you're going to want to give the generic, give this patient the Minicin. Now, I might have to pay a higher price because the pharmacy might say your insurance won't cover it. But when my provider said this is more efficacious and it's going to work better, faster, the other one, in his experience, didn't work as well. So I'm going to trust
Hmm.
my provider because I liked him. He helped me with other things, and that's what I got. Right. I
Hmm.
can't remember because that was a long time ago, if I paid out of pocket or if the insurance company allowed it. What they do is an override. So those things happen all the time. But specifically to GLP-1s, I know a provider who was telling me that they give instructions on dosing. Like when you get the pharmaceutical version with the pen, the self-injection, you
Hmm.
click a certain number of times. And the way the provider wrote the prescription was, let's say it was 3 clicks. The provider said 1 click only. And then the pharmacist calls that provider and says, you wrote the order incorrectly. And then the provider has to say, no, I didn't. I know that's not how it's supposed to
Hmm.
be prescribed. This is what I want on the packaging for the patient to follow. And then they get in this back and forth because the pharmacy, the pharmacist, they're both covering themselves.
Hmm.
And then the provider has to take time out of her day or their day and explain. And then, so what they're doing is they're kind of bypassing the manufacturer's recommendation and they're dosing it the way the provider told them to dose it.
Yeah.
And the provider is willing to take that risk because it's a very small risk.
Sure.
And those types of things happen all the time. So,
Wow. That's
yeah,
crazy.
I
It's
know.
very frustrating. Like when, yeah, people are just, just want to trust your doctor to be able to prescribe what like they are licensed to prescribe and not have to worry about the back end stuff is
Yeah.
frustrating.
Well, I know, and I'll give you another example, like, okay, let's say somebody has a peanut allergy. This seems really bizarre, but oral micronized progesterone has peanut oil in it. So if somebody wants to take progesterone, they're ready to take hormone replacement therapy, they have to find a different solution, right? So is there a compounding pharmacy that can basically they're making their own medication with all of the active ingredients, just like GLP-1s you can get at a compounding pharmacy. So that's something a patient may need. So this is just giving you examples of how important it is to have the right provider.
Hmm.
And I can ask these questions just because I know it and can say to my client, are you taking progesterone? How is it working for you? There's also topical progesterone. You
Hmm.
can take it. There's also rectally, administered progesterone, which a lot of providers like. So there are different formulations, there are different manufacturers. Like I've heard a lot of clients I have who are on hormone replacement therapy that Dottie is one brand name of estradiol patches. And then there are other manufacturers, and one manufacturer might work, but another one might not work for that patient. And
Interesting.
it's also important to know, like, when you start a dose of either estrogen, progesterone, or testosterone, this is another reason why you need the right provider. They may make dosage adjustments over time. They're also going to get your labs more frequently. So every 3 to 6 months versus once a year, because why not get that dosing right sooner so that you can
Yeah.
get best relief possible, the right kind of support, and improve your quality of life.
Yeah.
And it's, all of these hormones, this hormone replacement therapy, it's all working together. So my dose of progesterone, estrogen, and testosterone could be very different. And
Hmm.
I'm on different doses of all of those from when I started.
Yeah.
Dosage adjustments need, it's like fine tuning. So it's not just a one size fits all. And that's
Yeah. It's not
another,
set it and forget it. You got to like
yes.
monitor just like anything else. Yeah.
Yeah. So it's just finding the right person. So
Interesting.
yeah.
Can I ask what I love that you've got your checklist. So like when people come and like like talking about symptoms, I think sometimes we just think that the things that we go through in life are just normal life things, right? Like, I mean, I remember when I was going through it, I didn't have hot flashes, I didn't have a lack of cycle or anything like that, cycle irregularity, and like those seem to be the two big things that like immediately some providers, maybe the ones that aren't as experienced, will be like, well, if you don't have hot flashes, you're still young, you're only 42, and you don't have your cycles are still normal. Like you just are immediately dismissed as like not being in perimenopause, right? And you talked about, I think, like some high estrogen markers, or like maybe some, like most of the time we see the people that have like the low estrogen, right? Like you're coming in like irritable or things like that. What are some symptoms of like high estrogen? Is that a thing?
Let me give you, and this I'm looking at this client's list here. So she had 17 check marks on low estrogen. She only had 3 under excess estrogen. Now, keep in mind, some of these symptoms cross over, right? It's not like
Yeah.
if you have this symptom, it's only related to estrogen. It could be thyroid. Like if you're
Yeah.
sluggish, you have brain fog, or your metabolism is slower, that could be low estrogen. That could be high thyroid,
Right.
right? And so that's why it's important to look at this sheet all together as one piece of it and say, what's going on? Like, how are they? Because, it's kind of a symphony. Everything's working together,
Hmm.
all of the hormones, and one can impact the other. So, excess estrogen, weight gain, fluid retention,
Hmm.
headaches, irritability, breast pain. That's actually a really big indicator if you're hormone replacement therapy or estrogen is too high, that's one of the hallmark symptoms that I've seen clients experience. Heavy bleeding, irregular bleeding, clots with cycles, short cycles, endometriosis, depression, and food cravings. So, and food cravings, once again, that could be insulin, right? Your
Hmm.
cortisol could be high, your insulin could be high. That could be related to food cravings.
Yeah.
So, this is just kind of the beginning piece of it, along with the labs, and then talking to the client about what is their dieting history. Have they been eating, 1,200 calories and they've been dieting for 5 years? Maybe they're not eating enough food. And
Right.
I had a recent client like that who just can't get rid of their visceral fat, like that midsection or what they call meno belly, which is a horrible name. I hate that. And it's, I think we're just conditioned like that diet culture, like we need to exercise more and eat less. And it's back to another example of why that doesn't work, right? And
Hmm.
that us starving ourselves is not helping our hormone function. It's not
Yeah.
helping us function overall as a human being. And so it might mean that we have to reverse diet this client and have them start increasing their calories by 100 to 200 calories a week. And I observe them very closely, but that's a difficult thing for people to wrap their heads around. Like, what?
Very much.
I want to lose weight and you're telling me to increase calories?
Mhm.
And then I have to go and explain. So, if anybody's out there listening, if you Google reverse dieting, metabolic adaptation, or adaptive thermogenesis, you can read more about it, but it's essentially your body is slowing down everything, right? It's down regulating your hormones to keep you alive. Like
Mhm.
that is your body's number one job
Yep.
is survival for you. And
Yep.
it doesn't care that you want to lose weight. It doesn't care that you don't like the way you look or you don't fit into your clothes. So it's important that we have a plan on how to get you feeling better because your body, your health needs to be optimized. And in a lot of cases, it is hormones.
Yeah. When I was working with nutrition clients and we were talking about reverse dieting in that exact same scenario, I challenge them to say, okay, instead of when we are going to increase your calories, I want you to say, I'm increasing the amount of nutrition I'm putting in my body. Right. And when you say nutrition or nutrients instead of calories,
Yes.
sometimes there's a little switch in the brain, right? Like so when all of a sudden I'm like, okay, let's take away more nutrition. Okay, let's take away more nutrition. Okay, it's not working. Oh, I wonder why it's not working. Right. But when you talk about adding nutrients, adding things that your body needs, there's just a mindset shift I think that can happen.
Oh, I
And
like that a
that
lot.
makes, yeah, it just makes more sense, right? And again, that's like, it's diet culture. And typically it's the female brain too. I don't think I've had to have that discussion with many males, which whatever, that's a whole nother topic, but we are just wired to think that we don't need as much or, I need less, right? Like your body is literally hanging on to stored energy because it may not think that it has enough energy or nutrients coming in, right?
That's
Like
it.
it's
That's
kind
it.
of it's just a mindset thing again. And when we're talking about adding calories, like we very rarely are like, oh yeah, you need to eat more peanut butter and jelly sandwiches, or you need to eat more whatever. Like we're like, add fruits and vegetables, add protein. These are nutrients. They're not just calories. Like in our brain, yes, they are. Like that's providing energy, but sometimes if we can change that shift in how we are thinking about what's going into our bodies and what it's actually doing for us in a positive way, I think it just makes a big difference.
Yeah,
Yeah.
absolutely. I love that. And I mean, that's
Use
all I
it.
can say is like, yeah, it's nutrition, it's nourishment, it's like
Hmm.
feeding your body, it's making you more capable of doing the things that you feel like you haven't been able to do. Might even lift your brain fog or it might help your hot flashes. You might lose some weight, you know,
Yeah.
just by
Yeah.
like tiny little, but that is a great way to reframe that. I think
Yeah.
that's great. Yeah, it's
Awesome.
retraining people's brains who have just been for so long, even when people start to lose weight, it's like, well, how do you know it's going to be time to end? Like, when do you know? Like, we can
When are you
definitely,
small enough? Yeah. When
yeah,
are you enough?
when are
Yeah.
you going to be happy? Exactly.
Yeah.
Like, I had a client who's in menopause. She went to New York last week. She took a deload week, which I was super happy about. She just did Pilates, no strength training, and she bought a pair of pants. And she was like, and they were a size 0. And I said, Hey, that's great and everything, but you know what? You felt good in those pants before you knew what size they were. So, like, doesn't even matter what the size was. You felt amazing, and you also felt amazing when you shopped your own closet last week before you left for New York, and you were putting clothes on and not even looking at what the size was, right? So, get away from looking at the size, get away from looking at the scale. I know it's hard. I know it's hard. I've done the same thing, and I have to tell myself all the time to do that. And you never lose when you go back to how are you feeling? How are you living? How are you sleeping? What's your energy like? Your mood? Like, those are the indicators of if your body's happy and if you're going to be happy. And I
Yeah.
know it's hard. I
Yeah.
know it's hard.
No, it's challenging, but that's why we're here. That's why we're here.
I think just one other thing that popped into my
Yeah.
mind that when people do go to providers sometimes, I see this quite often, and I just want people to be aware of it so they can make the best decision. I had a client maybe a year ago. I don't work with her anymore, but she started strength training. We still kind of DM each other on Instagram. And her provider, I think she was like early 40s. Her provider did not want to start hormone replacement therapy because she was still cycling. And there's a myth out there that you should not take hormone replacement therapy if you're still cycling. That
Hmm.
is not true. You still may need support as you're going because it is hormonal chaos and it's not like this perfectly beautiful bell-shaped curve or something. Your progesterone comes down and then your estrogen. It's kind of all over the place. Back to that
Hmm.
hormonal chaos. Her provider prescribed an IUD. She said, "You're not old enough for hormone replacement therapy." I've also heard of providers just prescribing oral contraceptives. So
Yep.
now what I'll say is, that is going to stop or help some of your symptoms. However, it is not working on the root cause. You are not like providing support, like back to like give your body what it needs. You're not replacing hormones, you're basically shutting them down is what you're doing, right? Those are
Hmm.
synthetic hormones, and what I think is astounding is that some providers will discourage women from even considering hormone replacement therapy because they think it's dangerous or causes breast cancer. Those are some of the studies that have been completely refuted, yet they'll prescribe an IUD or
Yeah.
oral
Birth
contraceptive.
control.
It's like, that's like shutting down your cycle. So
Hmm.
why is that better than it doesn't make sense to me. And there's progestin in an IUD, not progesterone. We
Right.
want what's equivalent to what we produce in our own bodies. We don't want like that synthetic
Synthetic.
progestin. That's not doing the same thing. And another thing that providers might do is just a lot of times they're giving their patients an antidepressant and just saying, let's just try an SSRI. Let's see how you do with this. And that is not dealing with the root cause, right? That is just putting a band aid over it and saying,
Is
let's
that
see if we,
Wellbutrin? Is
yeah,
Wellbutrin?
Wellbutrin is one
Okay,
of them.
that's what I was. Okay, sorry. I remember calling. This is exactly what I went through. So I'm like, yes, I remember this. Like when I had my initial symptoms, and we've already talked about me, but that is all. It's exactly what happened to me. Is like, oh, here, try birth control. Oh, here, try Wellbutrin, and it was
Yeah.
yeah, and I did not want to do any of that. So those are.
Totally forgot that they gave you Wellbutrin. Yeah.
I never started it. But it's just another case of like, a provider was doing what she did. Like she knows how to do. She wasn't a perimenopause or menopause specialist. And so I got another opinion on somebody that was. And I'm now on the estrogen patch and progesterone. I've been on that for I don't know how many months now, but the symptoms that I had originally are gone. Like I was fatigued, irritable, like minorly, like I couldn't find joy. And like I was watching my kids do karate and I felt like I just had this mask on my face of like, normally that brings me so much joy. And it was like, I was almost crying because I was just like, couldn't feel anything. It was crazy. It was so scary, but I knew I wasn't myself. I knew that was it. And it wasn't like, I'm not depressed. Like something else is going on here. Like, and I, take care of my body. I take care of my food. Something was going on. And so, like you said, like I had that white coat kind of syndrome of, yeah, like they're telling me I'm depressed. Oh boy, like this is kind of, but I knew that there was another door to open and I'm really glad that I did. And so I think I love talking about this stuff because like the symptoms that I'm feeling, I'm sure somebody else felt, and like knowing that you don't just have to take birth control. Like they're trying to do there is manage one aspect of your cycle to remove maybe one symptom so that you feel a little better, but it's not going to, like you said, it's not going to solve the root cause here. And hormonal therapy, or sorry, HRT is not going to, like, it's not a root cause problem solver either, but it does cover a vast many more symptoms, right? And it's just overall, like, it does help in concert with diet, exercise, and all the other fun things, stress management being another big one.
Yeah.
Yeah.
Well, I'm glad you found another provider. This is a
Oh
great
yeah.
reminder. Trust yourself, right? You trusted your symptoms and you found the right treatment and you're feeling better. And that's how your body needed nourishment, right? A different kind of nourishment
Exactly.
than food. That's
Exactly.
the right kind of support. And the other thing, too, that I'll mention that when we start, our hormones start to diminish, we're at greater risk of osteoporosis or osteopenia. So our bone health declines. Our cholesterol markers can go up with no changes in anything. If you're exercising the same, you're eating the same, that's the other frustrating piece. So this is really a way, for cognitive help to try to prevent dementia, bone health, cardiovascular health. So important to be able to, those are other reasons, like health reasons, that bioidentical hormone replacement therapy is, everyone deserves to have the conversation with a provider who knows how to do that. So,
Yeah.
and I
I
will
hear
give a
you.
teaser that we are hopefully next week going to have a physician who is certified and got menopause certified just, like, I think 4 months ago, Dr. Hilary Bassett.
Yeah.
And I work with her a couple of hours a week, with her patients. So I kind of see this all day long from that side.
Yeah.
It's, I work with her patients on all of these things, the lifestyle, the nutrition. We don't have Sheena to help them. So I have to tell them to go, lift heavy.
Lift heavy.
Her patients, Sheena.
Yeah. We could put out, if yeah, when we get her on, maybe we can have people submit questions for her.
Oh, that's a great idea. Yeah, we
Yeah.
can post that. Good idea.
Be really
Absolutely.
fun. And anybody else they want to see come on. We've got a Rolodex that we need to start working through of
Yes.
guests. You'll see.
Yeah, so send us a DM if you want to be, if you're a client or a former client, we also want to include you on the podcast, but we're
Yeah.
we're going to expand and have some guests on that we think you'll
Yeah.
really enjoy. So,
Hopefully.
I
Awesome.
think that's good for today.
Yeah,
Anything else?
that was great. No, I mean, I always just I love talking about the symptoms of perimenopause because I just think that, like, there's people out there that just don't know still that it's like, oh, like, I'm maybe in perimenopause, like that's a thing, right? And so I think we covered a lot of them, and I think that's awesome. And if people have more questions, or like if they want us to go even deeper into symptoms and symptom management and stuff like that,
Yeah.
we've both gone through it or are going through it currently. So, and again, I still think it's still kind of new. I think the idea of, like, people being in their late 30s or early 40s and possibly having, just being able to get support, like you said, sooner rather than later, and it makes
Yes.
that whole transition into menopause just that much easier from what we're seeing, right? And the science that's out there, I think, supports that. Like you mentioned that earlier, is the sooner you get help in perimenopause and support, hopefully less. One of my friends calls it hormones instead of hormones. It's
Hormo
hormones. Yeah. So yes,
Yeah.
a little
Yeah,
crazy.
and I was thinking about today too, and I was like, how many times did I hear people say, I don't even remember in what context, but, "Oh, she's hormonal." Like it's bad, right?
Hmm.
Like it's a negative thing, and it's like, that's so frustrating because it yes, it does change our psychological,
Hmm.
our physical, who we are, and it just means that we need some kind of support, or we need
Hmm.
to change our habits to, just make sure we're getting what we need and we're feeling our best at all times. There's nothing wrong with us because our hormones are shifting. That's who we are. And,
Yeah, it
you know,
happens.
so I know. So one quick thing, Sheena, I
Sure.
change my twice a week. Today's change your patch day,
Ditto.
Mondays
It's
and
also
Thursdays.
my. Me too. We're on
So,
the same schedule. Look at us.
oh, look at that. Same shirts, hormone
So,
replacement. So this is it. That's how small it is. I won't
yeah.
show you guys me putting it on, but and then
Yeah.
this is my testosterone. So I just
Nice.
literally just like squirt it, put it on my arm, rub it
Rub it
in.
in. Beautiful.
I figured I could just show people how easy it is,
Yeah.
and then that's it.
Well, I did have one more question. What's the difference in estrogen patch and estrogen pill? Is there a absorbency? Is it just whatever fits people better?
So, yes, once again, there are multiple formulations. And what I can tell you, I don't know as much about oral versus the patch. And I have to look it up, but oral estrogen, I think there is a slightly elevated risk for side effects, and I don't know if it's breast cancer. I have to look it up, but I do know that preferred administration is the patch. So
Okay.
we
Yeah,
can have
that's
Dr. Bassett go over that when she comes in.
nice.
That's
Okay,
going to
and
be
then I
the
want to
first
ask her. Okay, then our second question will be: we have a few clients that have a history of breast cancer. What options are available to them, if any,
great
for
question.
HRT? Because that's obviously the cancer risk, right? I don't expect you to answer that, but I think that's everybody
We'll
knows
have her
somebody with
we'll
breast
have her
cancer. So
cover that.
okay,
Awesome. Yeah, those are 2 great questions, and then we'll ask people to submit. So if anybody is listening to this and you wanna submit a question, do it now, because if you get it in, we've already got 2,
yeah,
then you'll be 3rd in line if you get to us
yes,
next. So
awesome.
hopefully that helped people dispel some myths, gives you some ideas how to advocate for yourself and
Yeah,
nourish yourself hormonally and
nourish.
otherwise.
Eat more nutrients. Eat more
So that's
nutrients.
it. All
All
right.
right, G.
Thanks,
Thanks for the
everybody.
time. Bye.